Pooing and spewing, I like that. Let's go over some cases. Vomiting and diarrhea is going to come in a variety of forms, right? You can have a 3-week-old kid, mom says, baby's been vomiting, spitting up, trying to differentiate the two for several days. A 10-month-old, it's coming out of both ends, right? They've got brothers and sisters who are also sick, and a 6-year-old with bloody diarrhea. So we'll go over all these different types of presentations. So kids are different. They have unique diseases. We'll talk about colic and pyloric stenosis. They have different presentations. A young child with appendicitis, they don't wall off that infection real well. Their peritoneum can't really do that, or mentum can't do that, so they tend to present more perforated than older patients. Parents and kids are often poor historians. You're asking, well, did the pain start first? Did the vomiting start? I don't know. It just all came together. Fear of the white coat. You walk in the room with a white coat, what is that young kid going to do? Burst into tears. I stopped wearing a white coat during residency a long time ago. Sneak a peek. What does that mean? It means look at what the kid is doing before they say you. Look around the corner, look in that room. If that kid's climbing all over the gurney, climbing all over mom, there's probably not a whole lot going on. What is that kid going to do when he sees you? Boom, makes a beeline bomb, right? Hides, climbs into mom's lap. So see what he's doing before he sees you. Get down at the child's level. Sit down on a gurney next to the bed. I sit on the kid's bed. I sit next to mom. I put the baby on mom's lap. I get down. Don't look down at anybody. Get down at their level. Distract with toys. I have a little frog on my badge that you push a button and lights light up. Something to distract the kids. Something to say, hey, you're kind of cool. What is that you've got on you? Take the diaper off. Hernias, right? Incarcerated hernias can present with vomiting. Make sure you take that diaper off. Also look at teenage boys. I missed a case of torsion in a teenage boy because I asked the resident, did you check down here? Did you ask about, did you use stuff? Yeah, she said, oh yeah, it was normal. Well, she had asked the patient. She didn't actually look. And that teenage boy saw this female resident walk in like, no, there's no way you're going to, even though that really was his complaint. He had said abdominal pain, but he really wanted somebody to check, but it wasn't going to be a female. So he's like, no, everything's good down there. And she didn't look. So you got to look because boys are not going to tell, especially a female provider. Rectal exam, just say no to rectal exams. Unless the complaint is the anus, unless mom says there's something going on down there, sure, go ahead and take a look. But a rectal exam is never ruled in or ruled out appendicitis specifically. I know how to get a peritoneal exam on an adult, right? You can feel around, mash the belly. The minute you approach a kid, what is that kid going to do? He's going to cry and get all upset. Have mom help you. Well, have the kid run down the hallway. A kid who can run down the hallway probably doesn't have peritoneal signs going on. Have the mom bounce the kid on their knee. So baby, bounce them. That's a good way to see if the belly's bugging them. Have kids do a basketball jump. Show me your highest basketball jump. It's a great way to get a kid to show you their belly's pretty good. Observe over time. Intussusception is one of those colicky things, right? They have pain and then they don't. They have pain and then they don't. Mom says, God, he was really in pain. We were waiting in the waiting room. We were driving over here. He was screaming in pain. Now he looks pretty good. Don't just discharge that kid in 2 minutes. Maybe you need to observe. I always tell parents with belly pain, it's like watching a movie. I'm getting one little snippet of this movie. We're going to have to see how this plays out. This may end up being appendicitis. Right now, I don't think it's appendicitis, but this may end up being appendicitis. We're going to have to watch this over time. So belly pain a lot of times is like a movie. Differential is going to depend on the age of the kid. So abdominal pain, vomiting in young infants, we'll talk about things like pyloric stenosis, that colic, incarcerated hernia, we already talked about looking in that GU area. Don't forget things like sepsis and traumatic brain injury. There should be another error. There we go. Just keep it, especially a kid who comes back, who's still vomiting the next day, that I think there may be something going on. Nausea, vomiting without nausea. The kid's a little more sick appearing. His vitals, he's tacky, and he's not getting better with IV fluids. Think beyond just good old gastroenteritis. Think beyond the GI tract. Pyloric stenosis, it's not dangerous, but obviously the kid needs to get diagnosed. He's not going to, get over this by himself. It's typically young babies 3 to 5 weeks of age. They have non-bilious vomiting. They're hungry. They want to take POs. They just throw it right back up. So they're starving. They want to take the bottle. They want to take that boob. But they're going to throw it right back up. They can come in dehydrated. Sometimes they look like little scrunchy old men because they're so dry because they've been waiting at home. Or maybe they've gone to maybe they went to the doc or they went to a clinic and, you're fine. It's a little spit up. How do you tell the difference? Right? Spit up is just a little bit. It's generally like during the feed. It's a little bit on mom's shoulder. Have you seen the vomiting you get with pyloric stenosis? It's pretty intense vomiting. It can shoot across the room. Mom gets all wet. You get wet. It's pretty intense vomiting. Again, it can be confused with spit up sometimes. Don't assume all vomiting is just spit up in a little baby. How do you diagnose it? Sometimes you can feel the pyloric, the little kind of olive, that kind of little lump there. Screw it. Just get the ultrasound. Ultrasounds are really sensitive for making this diagnosis. If this ultrasonographer is not great, or you don't have them at night, an upper GI sometimes, or sometimes you can have a false negative, you really think this is pyloric stenosis, and the ultrasonographer is kind of making cuts through the distal stomach and not really that pyloric area. So if you're really concerned or you don't have ultrasound, an upper GI can also give you that diagnosis, and you'll see that string sign as it kind of makes its way through that narrowed pylorus. These babies get admitted. In some countries, they treat them with IV atropine because they know it's spasm. They admit them, they get IV atropine for a few days, they go home on atropine, they never get an operation because they just have to overcome that spasm. Volvulus, we talked a little bit about yesterday. We looked at some plain films. Remember, they're born with this congenital malrotation that puts them at risk for the twisting. It's when they twist that they start presenting. They'll look like they're in pain. You have an irritable young baby. They won't tell, obviously they can't tell you it's belly pain. Sometimes you can't, but they're irritable. They're just cranky, not consolable. They may be grunting, they may be yellow. Any serious illness in a young baby, a couple weeks of age, can turn them yellow. They can become jaundice. They may be pale. They can have bloody stools. Obviously, you don't want to wait until the stools are puppy. That double bubble sign, that airless abdomen, I can't even. So you have a young baby, they come in, they're cranky, their perfusion is bad, they're irritable. There's just a sick-looking infant in front of you. You're getting a line. You have volvulus, GI things on your differential for a sick newborn. You shoot a KUB, you see this kind of gasless abdomen. Proximal air, because the air is not getting past that volvulus. Get on the horn with your ped surgeon or the PICU, wherever you're going to send this kid. Get on the phone early. The x-ray may not be conclusive. It may look relatively normal. An upper GI, again, will tell you, give you a diagnosis, you get that corkscrewing. We cover them with antibiotics. We're assuming they've got probably some necrotic bowel. These babies need to go to the OR. They need that thing untwisted. So get on the horn early. Bilious vomiting in a young baby. Difference is a little bit different. Think about malrotation. Think about incarcerated hernia. Congenital adrenal hyperplasia. That's that weird, they lack aldosterone, their sodium's low, their potassium's really high. Usually you can make that diagnosis based on the lab test. For whatever reason, they also can present with bilious vomiting. So it's on the differential. Intestinal hematomas, that would go along with child abuse, right? Kids covered in bruises, vomiting, bilious vomiting. Intestinal hematomas are on there. Older kids and vomiting, now you start getting things like pyloric stenosis. Again, incarcerated hernias, torsion. You gotta look down in that GU area, always, always. Think about head trauma, think about meningitis, especially a kid who comes in vomiting, you take him up, you send him home, he comes back still vomiting, right? Now you undress him, now you're noticing, hey, those are atypical bruises. Kid's got a fever, maybe there's an epidemic of enterovirus going around. Brain tumor. Usually those kids don't present with just vomiting. They usually present with some type of neurosign. So make sure that kid has a normal neurological exam. And sepsis. Sepsis is always kind of down that differential of any sick kid who's just not following the normal track. I give him IV fluids, he's still tacky, he's still looking out of it. Something else is going on besides good old kind of gastroenteritis or good old viral vomiting and diarrhea. Intussusception we talked about, that's a young child. It peaks around kind of late infancy. It's idiopathic in young. In older kids, it tends to be some reason. There's a Meckel's, there's a polyp, something that's making that lead point. They typically will have colicky pain for a few minutes, and then they're better, and then colicky and better. The longer it's there, the kind of more ill-appearing these kids will be. Think about it in the truly irritable, older infant, afebrile, cranky, not consolable. You all know the irritable infant kind of differential. It's on there. There's a reason it's on there. For some reason in intussusception, there's this weird brain, CNS, and GI tract connection. So intussusception can cause a lethargy. It can cause syncope. It can cause altered mental status. So think about it in a young baby, older baby, 6 to 12 months of age. Maybe there's a history of vomiting, maybe not, but the kid's altered. Syncopized, not waking up, lethargic, vomiting. Think about intussusception in that kid. Pain out of proportion to exam. Again, these kids act like something is, they're crying. It hurts. But yet their damn belly's kind of soft because it's not perineal. They've got twisted, dying bowel in there. Most will have belly pain. Most will have vomiting. Not a whole bunch will have bloody stools. Don't wait for that. That whole hematochezia stuff, They may not be guaiac positive. They may not have frankly bloody stools. Don't wait for that. We talked about some of the plain film things you see, that absent liver edge. The lights are on, but on that film on the left, that target sign, you're actually seeing the intussusception. Again, plain films are not diagnostic. You can have normal plain films and have intussusception. But if you get a plain film, you ought to know what might be there, because if it's there, you want to see it. Target sign, the crescent sign, you're actually seeing the intussusception kind of longitudinally. Absent liver edge, because you've just got that kind of mass thing covering up the liver area. Barium enema, air enemas, more. I've done this for a long, long time, and more. How you guys are doing air enemas? Do you guys know what enemas you guys or hospitals are doing? More and more places are doing air enemas. It's less radiation, obviously. It's cheaper. It's easier. It seems to be more successful. It's much less risky if the kid has a small area that's a little necrotic and it perforates with the enema. Much better to have air in your peritoneum than barium, right? Not everybody gets an air enema, or not everybody gets an enema. Some need to actually go to the OR. They have signs of peritonitis, if they have signs of perforation already, they have septic, they're shocky, those kids need to be resuscitated. And obviously you need to get the pediatric surgeon, the PICU people involved. There's not a PICU person in the world, not worth their weight in gold, that wouldn't want a phone call from you guys. They're going to inherit this kid in transport, right? Their kids will be sent from your place to them. They want to know about these kids early, whatever the diagnosis is. They want to help you. They want to give you some advice. Get them to give you some advice. Repeat enemas. They always said you've got one chance, right, for an enema. There are some studies that if it fails on the first attempt, there are some that look pretty good. The radiologist might try a second time for an air enema or barium enema, and sometimes they're successful. And here in this country, we admit after reduction. You reduce, they look good. Here, we tend to admit them. Watch them for a day, make sure they don't. If they're going to re-intussuscept, it's a small percentage, but they're going to re-intussuscept usually within the first 24 hours. A lot of other countries, they may discharge them home, but here, we tend to admit them. Appies, just a few points on kids. Their presentations are less classic. They may have more diarrhea than normal. Their belly exam can be hard because their omentum doesn't pack stuff down well, so they perforate more likely. Missed appies are more likely to have a second visit because they were afebrile in the first presentation, or they were hungry, they wanted to eat. They had more diarrhea than normal. White blood cell count, not sensitive, not specific. You can't rule it in or rule it out. It may lean you toward, it may lean you away from the diagnosis, but it's certainly not the be-all and end-all. Rectal exams, again, just say no. They don't make I love when the surgeons consent the patient and then I still got to go do the rectal. Really? You already decided to go to the OR. Why are you doing the rectal? Pain meds, antiemetics do not delay the diagnosis. If you're not a believer, you should be. It's cruel and unusual to allow a child to still be in pain, to allow a child to still be vomiting when we know it doesn't hinder our ability to make the diagnosis. You probably get a better exam. Ultrasound, if you're not doing ultrasound, use your first-line imaging, you should be. Get your radiologist on board. They're usually not the problem. It's usually the surgeons. A lot of surgeons still want a CT. So you've done the ultrasound, you know it's happy, and they're still ordering a CT. So, on a Monday morning, have a meeting with your Department of Surgery and say, hey, could we get on board? Could some of you maybe accept the diagnosis of appy in a kid, especially pregnant women? What we're doing at County USC where I used to be is an MRI. If the ultrasound was equivocal, you got a very limited MRI, just a few minutes, no sedation, kids over 3 years of age, avoiding CT scan. So that's also pretty progressive. Hemolytic anemia disorder, just a couple moments about that. It's out there, it's pretty rare, but I want to remind you, it's that hemolytic anemia, they get thrombocytopenic, they get acute renal failure. It's typically diarrhea associated. It's typically that E. coli that we all know and love. You can get a variety of ways, a lot of times with home processing of food, undercooked meats, petting zoos, daycares. What was this kid doing in the last 24 hours? The toxin causes this thrombosis intravascularly, which leads particularly to CNS issues and renal issues, renal cell death. Diarrhea is associated with most of these kids. It's a hemorrhagic diarrhea, usually within a couple of days. Some will be vomiting. Some will have this altered mental status or other CNS signs. The mortality is not insignificant, and a good chunk of these kids go on to have dialysis needed. They can develop CHF, hypertension. This is not a diagnosis you want to admit, so you want to think about it, and certainly bloody diarrhea. They get those fragmented red blood cells, their platelets can be low, they get elevated LDH and bili from the hemolysis. Your labs will point you kind of in the direction. You get an elevated BU and creatinine, again, from the renal issues, and stool cultures will grow out the pathogen of choice. Treatment, again, the recommendation is really avoiding antibiotics, avoiding antimotility drugs. It's really kind of supportive care. Cautious with the fluid resuscitation, again, because the renal issues. Again, you're making this diagnosis, you're suspicious of this diagnosis, get on the horn with whoever's admitting this kid, whether it's in your hospital or in transport. There are some things they can do down the line, like plasmapheresis and some kind of antidote stuff. But that's for our PICU people to kind of think about later. Red flags, abdominal pain, fever, and just vomiting. Think about urinary tract infections. No diarrhea, no one else is sick. Just have in the back of your mind, especially if they have suprapubic pain in a young girl. Abdominal pain, vomiting for several days, and looking a lot more dry than a couple of vomiting episodes would give them. Think about DKA. Abdominal pain and syncope or altered mental status. Again, think about intussusception. Belly pain, vomiting, and tachy that just is not getting any better. The kid's looking more listless than normal. You've given them IV fluids not resolving. Think about sepsis. Vomiting, headache. You're allowed to have a headache. You're dry, sure, but that should improve. Photophobia, all those things. Think about in the back of your mind meningitis. Vomiting, and another significantly odd complaint. There was a great case out in New York. Kid came in with vomiting, fever. They diagnosed AGE, but his complaint was thigh pain. All through the shot, my leg is killing me. That's not typical AGE. So if something's off, just step back and go, is this what I still think it is? Make sure the diagnosis you're stating is matching the chief complaint. What's the number one cause of pediatric abdominal pain? Red Hot Cheetos, right? That's the first thing I ask. These kids, and now they're even hotter ones than this. I got that slide from a long time ago. These things are toxic, and they can look like what at the other end? Bloody stools, right? Ask about Red Hot Cheetos. Gastroenteritis, very, very common. It's usually viral. The rotavirus vaccine was in, it was out, it's back in again. Vomiting is usually first. They typically have low-grade fever with this stuff. They don't typically have really high fevers. They can have some tenderness, but it's usually kind of diffuse and comes and goes. Signs of dehydration are not sensitive, but if you see signs of, if the kid hasn't peed in 12 hours, if he's tacky, if he has dry mucous membranes, he's probably dry. But you may not have any of that, and yet the kid is relatively dry. Electrolytes. We don't need to get electrolytes on every kid that comes to the ER. If I'm giving IV fluids, I tend to get lights, but not really necessary. You will want to get it on altered mental status kids, kids who have signs of moderate to severe dehydration. They have tenting of the skin, sunken eyes, dry, they're tacky. They haven't peed in 12 hours. I might check lights. They have that doughy skin of hyponatremia, prolonged symptoms. They're littler infants. I might check. Kids being passed back and forth between mom and dad. They're divorced. Nobody knows when the illness started. I might check. Keep in the back of your mind a UA, especially that young kid, prolonged symptoms, suprapubic pain, a fever, a girl, no diarrhea. Just think about urinalysis. Stool cultures, not necessarily. They're rarely positive. Think about it in epidemics, bloody diarrhea. They just traveled to another country. They're back. Rare instances of stool culture might be indicated. Oral rehydration, definitely recommended. We need to do this more. Avoid juices. You want to give something that's got a little bit better kind of electrolyte and sugar balance to it. Pedialyte works. If they're breastfeeding, you just want to do short periods, a minute or two, stop, just like you would be doing oral rehydration, 5 cc's, a few cc's at a time, 5 cc's, 15 cc's, a little bit at a time every few minutes. If they vomit, stop for a little while. Try again. Oral rehydration has low failure rate. Parents like it better. IV rehydration is not quick. You have to wait for the nurse to get a partner, right? It takes 2 people to put a line into a little one. Somebody has to hold the kid, somebody has to put the line in. That takes some time, and your rate-limiting factor is the size of the needle that goes in. So IV hydration is not quick. People think oral rehydration takes it longer. Not necessarily. Try the frozen popsicles. I love those. And they've actually studied those, and they seem to work a little bit better than just good old Pedialyte. You know Pedialyte, the popsicles, keep them in your refrigerator, your freezer, in your ER. You know how I see people trying to tear them. Just put a paper towel on one end, paper towel on the other end, snap them. Hand half to mom, half to the baby. Come back in 20 minutes. The kid will have taken the popsicle. Seems to be more successful than just kind of the rehydration liquid stuff out there like Pedialyte. I put down there, consider an NG tube. For the kid, you really want to get the kid tanked up. He's not wanting to take orals. He's a pin cushion. You've been trying for a line. The nurse is like on their 4th attempt. NG tube. NG tubes are not benign. They kind of hurt going down. But if your alternative is sticking this kid over and over again, think about an NG tube. Hydrate him up with Pedialyte that way. It works pretty well. IV hydration, again, if the kid's absolutely refusing POs, he's vomiting even just a teaspoon, if there's continuous vomiting in front of you, just throw a towel in and put the IV in the kid. Some will say give D5 normal to like stop the catabolism. No, normal saline is fine. It's like, how many of you guys have had normal saline when you've been dry? It's like holy water, right? I can say that because I grew up Catholic. It makes you feel like $1 million. I give at least 40 cc's per kilo. They're going to get 2 boluses. The money they spend on that ER visit is not the saline bag. The time was your time. It was putting the IV in. So make it worth their time. Tank them back up. Get them close to euvolemia. There is something that's out there. How many of you guys are doing this at all? This is kind of not caught on. I think we'll see more of it. How many of you guys have a pet that's gone to a vet, right? How do they hydrate them up? They tank them up between the shoulder blades. They bolus them up subcutaneously. You take them home, right? They've done that in the elderly for a long time in nursing homes. And now we do this in kids. It's been around for like 100 years. So you tank them up between the shoulder blades, and these are just a couple of studies say, you know what, it works. It works just as well as IV hydration. Get a little enzyme with it, kind of distributes the fluids a little bit better. Nurses like it, because they don't have to aim for a vein in a dehydrated child, right? They just put it in the shoulder blades, a little butterfly needle. So again, it hasn't quite caught on to a lot of ERs, but it's out there. Antiemetics, if you haven't used antiemetics in kids, you need to. Again, it's cruel and unusual in this day and age to allow a kid to continue to vomit. It's no fun, to be nauseated and vomiting. This is just a large study, looked at several trials, lots of different meds. Found decreased risk of vomiting if the med was given, especially at triage, decreased need for IV fluids, decreased need for immediate or later hospitalization, and a little bit increased risk for diarrhea. That's okay, we can handle that. This specifically looked at Zofran or ondansetron, 34,000 kids, not randomized. They just went back and looked at all these kids. 19,000 of them got ondansetron. Again, not randomized, so probably the sicker kids got the antiemetic, right? I don't give Zofran to everybody, but I certainly give it to a kid who vomits in front of me or vomited just to triage, because those kids are still probably not on the road to recovery yet. Initial admissions lower, return visits a little higher, but again, not randomized. These kids, the sicker kids probably got it. Return admissions a little bit higher, not enough to worry about. Alternative diagnoses were not significant, so there was no difference between which kids have API and which kids had pyelo. And Zofran did not appear to mask being able to make the diagnosis. That's kind of the key element here. ACEP agrees. ACEP had to actually write a paper on the subject because there were so many pediatric groups out there saying, don't give antiemetics. It's fine. We know that there are some extrapyramidal effects. We know they can be sedated. We know it might mask, but we know the studies out there say it probably doesn't do that. With Zofran, you don't have a lot of that. They don't get sedated and stuff like that. So we know it's used extensively by EM people and PEDS-EM, and ACEP was able to write a paper saying, look, it's safe. Go ahead and give them antiemetics. Diarrhea and probiotics, definitely think about giving probiotics. It's safe, and it seems to decrease their diarrhea. This was one study in antibiotic, or a number of studies looking at 82 studies in probiotics and antibiotic-related diarrhea. They looked at over 11,000 patients. Lactobacillus was generally the probiotic of choice in these studies, and it decreased their diarrhea. So I always encourage parents to try some probiotics in the kid who comes in with diarrhea. We don't have great studies on kind of the viral-associated diarrhea, but it seems to be just as helpful. Anti-diarrheals, things like Imodium, loperamide, not so much for little kids. The FDA actually came out in 2011 and said avoid things like Pepto-Bismol, kaopectate. There was a review of 16 studies in 2007. It said you're going to get more serious side effects in littler kids. Those are malnourished from the beginning. Those are more ill, bloody diarrhea, including things like death. So the recommendation really isn't to give anti-diarrheals, especially to little kids less than 3 years of age. A few more points. Again, I re-examine kids prior to discharge. I've seen that kid, I've tanked him up, maybe I've orally rehydrated him or started on that oral rehydration pathway. I'm pretty sure I'm dealing with gastroenteritis. Remember, belly pain is like a movie. I've now had that kid maybe in my apartment for a few hours. I'm just going to recheck that belly to make sure I'm not now looking more like appendicitis or another diagnosis. I don't PO challenge a kid in the department. Now, if I'm doing oral rehydration, they're obviously taking something in and taking something out, because that's how I'm hydrating them. But if I IV hydrate them, a lot of kids come in the evening, right? They've been with a babysitter all day, vomiting all day, mom comes home from work, it's now dinner time, kids vomiting, they come to the ER. By the time they go home after IV rehydration, it's like 9 or 10 o'clock at night. So I mash on their belly. They generally look pretty good, because IV hydration, makes you feel like $1 million. I send them home. I'm like, Mom, go home, go to bed. Try liquids in the morning. Try oral rehydration in the morning. If mom gets it and she has a way of coming back, There's no, I don't believe that there's a force to try. You got to take something orally before you go home. Making sure you're confident of your diagnosis. Refeed early. Once they can take solids, continue the solids. Lactose intolerance is pretty rare. Good old gastroenteritis isn't going to cause a significant portion of kids to have lactose, so they can go right back on their milk. And obviously, babies need to be rechecked, especially the younger babies, even if it's just a phone call. Have somebody from the department call the kid next day. You can get a whole host of information over the phone. Baby's fine this morning. She took her bottle. She ate her cereal. You can get a lot of information over the telephone. You don't need to necessarily bring those babies back. Take-home points, oral rehydration should be encouraged. Antiemetics are safe and useful in the pediatric population. If you haven't adopted it, please do so. Frozen rehydration popsicles, they're great. Remember, snap them in the middle. Half to mom, half to the baby. IV fluids are like holy water. Not every kid who comes in dry from vomiting needs IV fluids, but when they get it, it makes them feel like $1,000,000. Labs, again, are not necessarily, think about it in the altered, moderately ill, severely ill. Recheck a belly exam. Just document a good belly exam right before the kid goes home. Think about probiotics and return precautions. Bring that baby back if he's not able to take BOs. With that, I thank you very much.